Um, at the outset, I would like to thank the organizers for calling me here, in particular Dr. Milind Shah and Dr. Monica, who have been incomparable hosts. So, and it's always a pleasure coming here. Now, as you know, I'm from Chikitsa Ultrasound Training Center, and my lecture is Ultrasound Principles Involved in Prenatal Diagnostic Techniques, which Dr. Raju Saitya has already covered, so it's going to be basically a repetition of the same principles. Right. So, invasive prenatal diagnostic techniques, they are by and large chorion-Wheeler sampling, amniocentesis, and chordocentesis. Now, common indications for prenatal genetic testing, as we know, is if a congenital anomaly is detected during the first trimester ultrasound examination, or maybe abnormal results from aneuploidy screening, maternal age, or previous child with chromosomal defect or genetic defect, or a parent is a carrier of some balanced translocation or a monogenic disorder, or both parents being autosomal carriers of autosomal. So all these are various indications for prenatal genetic testing. And when we do prenatal, when we want to do prenatal genetic testing, then we have to carry out an invasive prenatal diagnostic technique, and that involves use of either a needle or a cannula under ultrasound guidance. Now, ultrasound, whenever you are putting a needle or cannula, the ultrasound guidance should be continuous. Means the needle should be visualized continuously from the insertion till it reaches the target, aspiration is done, and the needle is removed. Now, why is that required? To prevent any fetal injury or to minimize punctures, multiple punctures, or to reduce the incidence of bloody fluid. So, then we require continuous ultrasound guidance, and there are two possible techniques. One is a needle guide in a transducer like this. But the disadvantage of such a gadget is that once the target has been chosen and the needle has been advanced, the transducer cannot be moved at all. So the freehand technique is the preferred one, because you have freedom to manipulate if the position of the target changes abruptly due to fetal movements. Now, so freehand techniques are, as Dr. Raju Saitya mentioned, in-plane method, which is the preferred one, and out-of-plane method, which is less preferred. Now, every transducer has an ultrasound beam below it, which you can't see, and the convex probe has a cone-shaped beam, and a linear transducer has a rectangular shaped beam below it. And it has a thickness. This beam has got some particular thickness, and the needle has got to be within that thickness in order to be able to visualize it. If the transducer moves, if we don't have proper control over the transducer, and the transducer angulates a little bit, the needle, you're not going to see the needle. Or if the needle is not properly put in plane, you're not going to see the needle. So you have an in-plane technique which is preserved, and an out-plane technique here. You can see the needle positions are different. In the in-plane technique, the needle position is here, and in the out-plane technique, the needle position is here. Visualization of the needle is complete in the in-plane technique, and in the out-plane technique, you see it as a small dot. And you can first we'll look at the out-of-plane technique. Here we are putting the needle where that. Now what you do here is you put the transducer directly over the target site. Wherever you want to puncture, you put the target site below your transducer, and then the needle is put introduced at the midpoint of the long side of the transducer, and you can see the needle tip which is advancing through the towards the target site. Now the needle here is seen as a hyperechoic dot, and normally if you have inserted the needle properly, you will be able to see the needle tip. But if you're not very sure, if you lose the needle tip, you might have to move your probe position a little bit to identify the needle tip again. Now, one advantage of this approach is that one can see the adjacent and parallel structures around the needle, and therefore we can make sure that they are away from the needle. That is one advantage of this. But the disadvantage is that what you might be seeing is not the tip of the needle, but a cross section where the needle actually intersects the beam, and so the needle tip may be somewhere else. What you're seeing might not be the needle tip. Something about the in-plane method. This is the better technique, and needle is introduced at the short edge of the transducer, and then here the advantage is that you can see the entire needle as it advances, and also if you miss the tip of the needle, or if you lose the tip of the needle, you can still readjust the position of the transducer and continue with the procedure. This approach requires that the transducer, the needle, and the target are perfectly aligned. Now, technical aspects of ultrasound. The probe, usually we use the curvilinear probe. Almost always we use the curvilinear probe. The preset that can be used is the first trimester or the second trimester preset. First trimester for the chorion sampling and second trimester for the amniocentesis. But machines have recent machines have special presets which are useful for interventional procedures. Gains should be high to adequately permit visualization of the needle. There is a button called compound imaging. Compound imaging allows the beam to be fired from several lines of sight. So you get the beam firing from several angles, and this is a big advantage in using when you are doing interventional procedures. So use of compound imaging should be made, and you can also steer the beam in the direction of the needle so that you get a greater angle, and when you get a better angle, the needle visualization will be better. You can see that this beam is not coming straight down, it is getting angled here, and so this beam is slanted towards the needle, and you get better visualization of the needle. So you can use these technical settings to visualize the needle better. Harmonics doesn't help much. Okay, it might help, might not help, but it's really not of much use. There are some kind of needles which offer micro irregularities in the distal portion to enable better visualization, but in practice actually they have not really caught on with the practice. A few rules. The target, you have to choose the target after adequate scanning with the probe. Make sure that it is free of fetal parts and cord loops. The probe, now once you have identified the target, then you have to plan out in your mind the needle entry site, and once you've planned out that in your mind, you hold the probe fixed in that position, and then you take the needle, and once you start inserting the needle, the probe should not move at all as the needle enters the needle enters under ultrasound visualization. So while you're advancing the needle, your probe position, and you can see this image is quite static. Now, so the rule is that the probe and the needle should not move simultaneously. Both should not move simultaneously. Now the needle has to be visualized throughout the procedure, at the entry, at the progress, at the target site, and during the exit. And as I said, ultrasound beam has a thickness. Needle has to be within this thickness to be visualized. So we have and the maximum now. So you have to ideally put the needle in the center of the thickness of this beam, so that it's easy to remain within the beam. This Dr. Raju Saith has already told you how to estimate the length of the needle. If you put your probe directly over the target site, you'll get a particular depth. You know what that depth is, and the needle is going to be inserted a little more than that particular depth, which you get after putting the probe directly on top of the target site. Now you are going to hold the transducer in the probe in the non-dominant hand, which will generally be the left, and you will hold the needle in the dominant hand, which is the right hand. A few points about amniocentesis. Now the optimal transabdominal needle insertion site should be chosen carefully. You have to screen properly and choose the proper site for insertion. And effort should may be made to avoid the placenta whenever feasible, to minimize blood tap, and especially in Rh negative women. And though actually it's not that important a point, but still better to avoid. and avoid the umbilical cord insertion site while you are doing the amniocentesis, and large chorionic vessels. And here use of color Doppler will help. If you suspect or the site is not very sure, you can use color Doppler to avoid the insertion site of the umbilical cord and large chorionic vessels. Relative positioning of the probe and the needle. The ultrasound probe and the needle are both at 45 degrees to the mid-sagittal plane of the maternal abdomen. This is the mid-sagittal plane, and now the needle is at 45 degrees and your probe is at 45 degrees, so it creates a 90-degree angle. So you can see that the beam is coming at 90 degrees to the needle, and when it comes at 90 degrees to the needle, the sound is going to reflect off properly. So sound is going to reflect off properly when the surface is perpendicular to it. If it is slanting, then part of it will not actually reflect back. So this creates a 90-degree angle, allowing for optimal visualization of the needle path. Now the needle insertion has 4 stages: the abdominal skin puncture, the uterine puncture, the entry into the amniotic cavity, and advancement of the needle. And all these must be under continuous visualization. Now the abdominal skin puncture, we are introducing the needle at 45 degrees like this, and it should be inserted directly under the middle of the ultrasound beam. And then once you punctured the skin, you advance the needle around 2 to 3 centimeters, pointing towards the target. Now, while it is in the anterior abdominal wall, the needle should be visualized before it exits the anterior abdominal wall. So while we are in the wall, it has to. Now, if you look at this image, now the correct technique is, you can see the needle is going through the muscle and through the uterine, the myometrium. So you are seeing the needle here while it is in the anterior myometrium. But the wrong technique is where the needle has directly entered the uterine, the myometrium and the amniotic cavity. This incomplete visualization of the needle trajectory lateral to the ultrasound beam before it exits the anterior abdominal wall may lead to puncture of intestinal loops, because you can see here, this portion is not seen here at all, so it's possible to go through some loops here. So the point is that you have to visualize the ultrasound beam in the anterior abdominal wall before it exits the anterior abdominal wall. Now, uterine puncture. Orientation of the needle. Now, once you've entered the abdomen, the patient due to pain and might wince or might move or might contract the abdominal muscle. So before going further into the uterine, into musculature, make sure that the needle orientation is correct, and then you enter the amniotic cavity with a decisive fast movement to avoid tenting. And in case tenting occurs, then a small thrusting movement can assist in, or twisting the needle can assist in puncturing the protruding membrane. And then once it is inside, then you advance the needle to the target site under vision. Now, in case of a failed puncture, means you are not getting Leica or you lost the needle visualization, then you need to redirect the needle. So first of all, you stop advancing the needle. Then you move your probe and relocate the needle tip. Having located the needle tip, move the probe to relocate the target, and then advance the needle to keep the needle keeping the needle visualized. Now, this redirection should not last for more than a minute, after which you can extract it. If the attempt is unsuccessful, you label the attempt as unsuccessful. A new puncture site can be chosen, needle can be changed to avoid contamination. Very uncommonly, if you are doing a third trimester amniocentesis because some new fetal anomaly has been identified or suspected fetal infection, then we must be aware that complication rates in third trimester are slightly higher. Preterm labor rate is slightly higher. Number of needle insertion attempts are more than one in about 5% of the procedures. Blood stain samples in about 5 to 10%. Culture failure risk is higher. So these issues we need to keep in mind in third trimester. Now, chorion villus sampling techniques are transabdominal, transcervical, Choice depends upon personal preference, placental location, very important, posterior or not, presence of fibroids, whether uterus is retroverted or retroflexed. And if you are doing transcervical for the posterior placenta, then a 2% technique will be required, because one will give guidance and sampling will be done by the other. Now, bladder should be sufficiently full to allow visualization of the pregnancy, but should not be over distended. Now, in the trans-abdominal approach, we usually generally the single needle technique is used, and if the uterus is anteverted and the placenta is anterior, then a partially full bladder might help to get the uterus down into a more favorable position. But if the uterus is anteverted and the placenta is posterior, then the empty bladder might help to get the anteverted uterus in a more favorable position. Transabdominal approach, the needle would look like this. Here you can see the needle is here, and the needle tip is seen here. The needle tip is seen here, and once the needle reaches the target, then a series of back and forth needle movements are done to while maintaining suction for aspirating the villi. In the transcervical approach, the cannula looks something like this. It has a non-traumatic tip, and then you to advance it under vision here. Now, so the CVS cannula is given a gentle bend. You use the speculum and tenaculum to insert it into the cervix under ultrasound visualization. Once it is navigated into the placenta, then we apply to and fro movements and suction and remove the cannula in a single smooth movement. So difficulties in transcervical approach can be a long cervix, cervical erosion and infection, uterine abnormalities, deviated uterus, placenta covering the os, subchorionic hematomas. So these would be the issues in transcervical CVS. Thank you for a patient hearing.